everyone, nice to see you again. So welcome to Conversations with Adama, for those of you that are coming here for the first time, where I basically talk about what it means to live with a long-term condition, and in my case, sickle cell anemia. I thought it would be really good to have a really good friend of mine and my colleague, who happens to also be a midwife, to come in and talk about the whole journey that an individual might go through, somebody that presents with either a sickle cell, with either a genotype that could result into a long-term condition in their unborn child, or with somebody that actually already has a long-term condition. So say somebody that presents with sickle cell disease or any other condition, say diabetes, where you have to take certain things into consideration during their pregnancy journey. So she's going to take us through that pathway, so right from preconception, whilst you're actually pregnant, and also afterwards, and the sort of things that people do go through and to look out for. So hopefully you'll find this interesting. So as I just said, everyone, I've got a really special guest here with me today. I've got Claire Mathews, who is a great colleague of mine, but also happens to be a midwife. So welcome, Claire. Would you like to make a little introduction?
So like Adam has said, I'm a midwife, and that's what I've sort of trained to do. I don't specialise in this particular area. There are specialist midwives, so I'm sort of here to talk about just the generic role of our, what we can offer, and sort of I can give you the pointers and like who to speak to about what parts.
I think one of the main reasons why I wanted to talk about this really was because I talk about this very briefly in my last episode, in my last vlog, about somebody with sickle cell disease. Obviously I have my checkups, I have my 6 monthly checkups with my consultants, and in one of my checkups my consultants basically asked me the question of whether I was considering having children. But she was like, it's something that you really do have to think about, and when you are at that point in your life, you have to make sure that you come back to us and that we go through a proper process of care and planning, because there are lots of complications that can happen with somebody like myself with sickle cell disease. And not only that, but there's also the whole idea of making sure that my child also doesn't have sickle cell disease. So genetic testing for the sickle cell trait in my partner. So that was the first time where obviously I had to really think about that. I was like, oh, okay, so it's not going to be a simple process, and this is something that I really do have to consider carefully with my consultant, with my specialist. So yeah, is this something that you go through?
So this are ideal if when you have an existing condition, for you to have discussed it with a consultant and to have had good preconceptual care. That is by far one of the most important things for pretty much all of the main conditions. So if you're thinking, actually I'm considering starting a family, and you're under a consultant, I would say that that's a brilliant time to discuss it. The main thing that we prefer, is if possible, is that pregnancies are planned, so they will be more conscious about contraception and things like that prior to, so that you make sure that you decide when you become pregnant, so that things can happen beforehand. Good preconceptual care can make a massive difference to a pregnancy. So that's why what your consultants did is absolutely perfect. It's about suggesting it before you're thinking of it, so that you're ready and you've got time to prepare, and feel like make sure you've got that control of your condition, and you know what you would like, how you'd like things to be.
Yeah, because the other thing as well was so, I mean, at the time it wasn't the case, but now, for example, I take medication. I take hydroxyurea, which is something that helps to reduce the complications in sickle cell. And one of the things that they say is you shouldn't get pregnant whilst on this medication. So if you want to plan to have a child, I've got to stop taking the medication for 3 months. And that's really important, isn't it? That people, yeah.
Absolutely. So when we look at things, when as a midwife, we look at that would be ideal, because it does make a massive difference. So 3 months off your medication. So all of these things, you think that's already 3 months on top of your journey. So it's just making sure that you've made that plan so that your journey is, nice and seamless. And the last thing you want is an added pressure on top of that. Where possible, it is, it really is. Preconception is, I think, one of the most important things for your existing conditions.
So what are the sort of things that you would have to consider with an individual in terms of preconception? So
I sort of the things that I know about is that they would normally check your screen for your organs to make sure that everything's well within yourself before you start the process. They'll also recommend going up to 5 milligrams of folic acid, because normally it's 1 milligram, so they would recommend increasing that, and that's because that reduces the chances of neural defects in children. So having that extra folic acid is really important. The other thing they would look at is vaccinations and looking at prophylactic antibiotics. The vaccinations is they would give any sort of live vaccines, preferably before you're pregnant, because we can't give those during pregnancies. So we can give things like the flu vaccine and things like that, but any sort of live vaccine would need to be done before you fell pregnant. So if you're thinking in that side of things, the other thing that they would be thinking is just making sure as well that you're they sort of spoke through everything, that you're in a good position, you know, you're not having crises quite regularly, you know, so that you've got quite good control, so that you know they know what your triggers are as well.
Say other medical conditions, maybe what are the sort of things that they would have to consider? Would it be a similar thing?
So diabetes in particular, you know, we really recommend that for slightly different reasons, because of the fact that blood sugars have a massive influence on the way the babies develop, so that we need to keep an eye on what's happening. But to be honest, I would say any as a midwife, we sort of deal with the pregnancy journey, but the specialists that you see, you know, preconception, know more about your conditions, but also never discount how much you know about yourself. You know, actually, you know your own journey. So this is very generic. You know, every person, every woman's individual. So it's really important that your care is individual to you and you know your own body. So it's about trusting that as well. You know, it's about making decisions that are right for you. You know, we work to guidelines, but it's really important that, you know, that people feel empowered, that they know you're not a number on a page, you know, you are your person. You know, you need to.
Yeah, you know what? That is such a good point, because it can feel very sort of limiting. You know, you've got a healthcare professional in front of you saying, okay, these are the complications, these are the risks, this is what might happen, and it can feel really scary and it can feel really daunting. Or you might have the other way where you're just, you know, where you're told, oh no, you're fine. We truly believe that you're not going to get any complications. But if you in yourself feel that you're not strong enough to go through that process, then you've got to do what feels right for you, don't you? Take me through the whole, once somebody comes in, you know, they're already pregnant, this is at the point that they come and see you as a midwife. So what's the process? What's the care?
So the first thing that you do is you have a long booking appointment. So these are an hour long, and we ask lots of questions about yourself, your partner, family history, medical history. The idea behind that is we're looking for things that we might see that we might need extra support with. So midwives and GPs can provide care if there's no medical concerns to a healthy pregnant woman throughout their time. However, we've got the most fabulous consultants who, if we've got things we think actually this isn't in our realm of, you know, our sphere of practice, what we do is we arrange for you to see them. So this is sort of just going through to make sure we don't miss anything. So for example, if we find out, you know, for example with the sickle cell, we would actually refer you to a consultant, because as I said before, midwives, we love to do the, you know, the general chat, but the important stuff is, you know, having somebody who's got the medical knowledge who will support you during pregnancy. So at that appointment, we will normally arrange that. Hopefully, because you've had your preconception, partner testing's already been done. If for any reason this wasn't quite as planned as you were thinking and partner testing hasn't been done, at that point we would refer you to our screening team, and one of the midwives who specialises in genetic counselling would contact you and your partner and arrange a blood test for your partner. They will try and do this before 10 weeks of pregnancy, because that makes, you know, if they're taking that, and the idea is they want to do that before 10 weeks to make sure that you've got the options, you know, available to you. That is a very specific part of midwifery, and it's a very specialised thing. If ever you have any questions about genetic testing and things, obviously it's great to speak directly to, you know, your team. However, there is also the ARC website, which is Antenatal Results Committee, something similar, online. So
I'll signpost people to that. So great, thank you.
Perfect. So that's really, a really useful thing. So that would be the other thing. So the other thing I was going to mention is flu vaccine. Well, if you haven't had it already, we will recommend it. So, and whoever knows what other vaccines we might be having hopefully coming up. And the other thing I was going to mention, just at this stage of early pregnancy, is that obviously dehydration can be a massive trigger, for a sickle cell crisis. And one of the symptoms of pregnancy quite often is vomiting. So whereas some people might get a little bit sick and be like, I would suggest early help, going to your GP really early and going, actually, I'm starting to be sick, think about antiemetics, and then the GP is able to completely help you with that side of things. But rather than waiting to a point that you're getting dehydrated, and then it's almost harder to go backwards. So being quite cautious of your own, like we were saying earlier, your own medical and knowing your own body. Yeah. But it's worth just mentioning that, and particularly if you were to hit a hyperemesis situation, that would be very, very uncomfortable.
Gosh, yeah, I can't imagine the thought of having a crisis whilst pregnant and also trying to not vomit. Oh my goodness.
Yeah, exactly. And that's the key, is to really, that's why we go hyperemesis or any sort of sickness, especially if you know that that's something that triggers for you. It's definitely worth getting in nice and quickly. Yeah. So in case you haven't noticed, early is my special theme of today. And we would normally also recommend for an anaesthetic review at the same time as, when you go to see the consultants, at one of those you would see an anaesthetist, because we know that for anaesthetists, it's a lot easier for them if they've met somebody who they might have any sort of issues that they might have. If they've met them whilst in pregnancy, they're prepared, so that when you come in labour, because labour doesn't tell us when it's going to happen or how it's going to happen. So it's nice that the team know, there's a plan for you.
Good point, because I definitely know in sickle cell, they always, the whole anaesthesia thing is always quite up there. So every time I go and if I had a tooth procedure or I had surgery, being a sickle cell patient, they really had to take that into consideration, because certain types of anesthesia can again increase your chances of having a sickle cell crisis. So that's why. So that's really useful to know. Okay.
So what we love in maternity is we've got time to prepare for the big event. There's not many times that you're going to be going into hospital 9 months before, and we can go, right, okay, let's get everything sorted, make sure that everybody knows that we've got the right care for you. And like I said, there's no prescriptive, everybody with this has this, it's going to be dependent on you and your own self, but it's just handy to know. So that would be the other thing we do at booking. And then, to be honest, your care when you see the midwife, so you would see the consultants, you'd see them quite regularly. It looks like by the time you hit about 20 weeks, you'll be seeing them 4 weekly. So you have your normal scans, you would have your scan that we offer to all people, your first scan, and we also offer a 20-week scan. So that fully checks over baby. And then because of with sickle cell, there is an increased risk of having a baby with IUGR, which is a smaller baby, so babies that don't grow quite as sufficiently in the womb. So what happens is when you get to 20 weeks, every 4 weeks, you're then offered a scan. So you would have a scan at 24 weeks, 28 weeks, 20, so 32, look at my maths, and 36, 40. So the idea is we're making sure your baby's growing, and by having these scans regularly, we can actually see like a curve. So because one growth scan doesn't tell us a huge amount, but actually a lot of them shows us that we know the projectile for your baby, and at that point we can start to think about that. So that's one of the main differences. Obviously, sort of looking after your condition as well. But from a midwife's point of view, you see us as normal. What we would do is we would send off a sort of culture, a urine culture, every 4 weeks approximately, so once a month. And that's because of the greater risk you have of urine infections. And in pregnancy, we really don't want you to have an urine infection, because it can cause complications, because your immune system's lower. We want to keep you well. So the low dose of heparin, some women might be offered that during pregnancy, but we know that if you were an inpatient, it would definitely be recommended. And also we would normally recommend it 7 days from delivery. If you were to have a cesarean section, it would actually be for 6 weeks. So
Yeah, just for those of you that are not sure, so we've probably got our our medical practitioner's hat on. For those of you that are not,
Sorry, yeah.
heparin it's basically, it thins the blood essentially. So it's an injection that makes sure that your blood is flowing nicely. So it reduces the chances of having blood clots. So yeah.
Sorry, yeah, you get a pharmacist and a midwife together and it all goes wrong there. So, I always see the midwife appointment is a great time for you and your baby, because it's really important that with the medical journey that you don't suddenly go, oh gosh, I haven't had time to be with my baby, and making sure, that you have that sort of time together, that because when you're pregnant is one of the best times, it's your bonding time with your baby, getting to know your baby's movements, enjoying the pregnancy. So that's sort of our side of things, but from a midwifery point of view, so your normal appointments will go as normal. The one thing that they tend to recommend is that deliveries after is between 38 weeks and 40 weeks. They do tend to recommend you don't go overdue when you're with sickle cell disease, and what they would say is they would recommend sort of inducing you before your due date. However, some babies decide to come before then anyway, so but it's just important to know that sort of with labour care, what we would then say is actually you'd come in as normal. You probably come in when you feel like you'll start labour starting, or if we're inducing you, but we would recommend continuous monitoring of the baby during labour. And the reason behind that is because it's a great opportunity for catch if there's anything that's happening that might be stressing your baby out. The other thing we would do is we would sort of want you to be on labour ward, because we know that keeping you hydrated is really important, and obviously labour is going through labour is like running a marathon. It uses massive calories and masses, so to try and stay hydrated enough is tricky. And obviously when you want to keep your condition under control, we sort of almost want to be able to get you fluids and do certain things. At the moment, the recommendation is definitely that you have your baby on labour ward and have continuous monitoring. However, like I said before, obviously each woman's journey, and it's these are recommendations. So if you choose to go outside of that care plan, there are people you can speak to talk about it, if that makes any sense.
At this point, would you, you touched very briefly about, this is the, before 10 weeks point, you could test if the baby might have sickle cell, right? But at this point as well, could you also test if the baby's got other conditions? So sickle cell, is this where you would do the heel prick test, the bloods, what is it called?
Yeah, so we've got a couple of things. So I actually did some reading last night. So when if you both have a chance of the sickle cell, they do offer a capillary test, so a blood test for the baby once they're born, which they send off, so they can double check that. But actually also what we do is we offer all babies, so every baby in the UK is offered a heel prick test, and the newborn blood spot, and it's 4 spots of blood out of the baby's heel, and it's done on between day 5 and day 7, but preferably close to day 5. The reason behind that is just baby's blood, so we're just checking for these conditions. So we do check for a range of conditions. We check for sickle cell, we check for cystic fibrosis, and we check for congenital hypothyroidism.
Okay.
And then we check for 6 other massively rare conditions that are metabolic conditions. Okay. I'm not going to go too far into them because they basically, I can't pronounce most of them, but also they're very specific. They're massively rare, particularly the metabolic conditions. They sit in the 1 in hundreds of thousands, some of them. However, it affects the way the brain develops, like molecules can't be processed, and it affects the way the baby's brain develops. So we catch them at day 5 and we put them on a specific treatment plan for life. So that's sort of the key. So so from a diagnostic point of view, sickle cell can be diagnosed at the newborn blood spot. To be honest, these days, because of the fact that most people know their status and we check partners, we tend to know which babies we're looking for. We don't often get a surprise sickle cell situation where babies have got sickle cell that we really didn't expect. Normally by this point we're starting to prepare for the fact, and babies are also if a baby's born with sickle cell disease, they're also often early vaccinations, and also quite often some antibiotics, but you'll probably know more about that than
me. And I guess also that baby is going to be put into some sort of specialist pediatric care, pediatric care. Or whatever condition.
And to be honest, if they think that your baby's going to be born with, because if you go through screening and your baby's going to be born with sickle cell, then you probably get to meet the paediatricians even in pregnancy. Quite often we work quite closely, so that if you're seeing the consultant, the paediatrician will come down and talk to you about what that would mean for your baby, what they suggest. So actually those consultant appointments quite often we work in tangent with the paediatricians. So then, and if we think, oh, actually baby might have a few issues when they're born, so might end up on the special care unit, you know, we'll show you where that would be, you know, so there's great opportunities to go through that with you.
Right. Wow. I mean, it's really encouraging to hear that there's really, really good care out there, like right the way from the start all the way to the end. That's really encouraging. And actually it's quite like, you know, all the like you said, getting pregnant is a scary thing, isn't it? So yeah, it's very daunting. So it's really nice to hear that you're going to be looked after properly from a whole set of different healthcare professionals. Yeah.
Absolutely. And it really is, it's about making sure that I just think, always ask questions. There's no such thing as a silly question. If you're not sure, let us know. And like I said, if we don't know the answer, we'll find somebody who does. You know, it's all about making sure that you feel like you know where everything is, and you've got it right in your head, you know. And also, you know, with all pregnancy, the one thing I say to everybody is it is a stressful time, and if at any point you feel like it's stressful and you're worried about yourself, please talk to us. You know, there's no stigma attached. If anything gets much and you start to feel anxious or you're worried and you've got any concerns about your mental health, please let us know, because the chance, you know, we can arrange you support. You know, the key is not to sit at home worrying, because probably by the time everything you can what if, by the time you've got to the end of the list, we probably could have supported you. So it's always what I just say to everybody is, yeah.
Oh, thank you so much, Claire. That was really, really helpful. Oh my gosh, I've learned so much. So thank you so much for that.
No worries. So yeah.
It was such a great job. It's so like, when I get pregnant, can you be my midwife?
Oh yeah, of course. I'll just pop up the M25. Hey.
You never leave it.
I'll move in, it's fine.
So one of the things that she actually mentioned was, she mentioned the word stigma, which is actually my next episode. Stigma is a really big thing that is unfortunately experienced by lots of people with different medical conditions, including sickle cell. And I think it's the more that we talk about conditions, the better it is in making sure that the better we can reduce issues such as stigma. So I think it's very important that we discuss stigma on its own, in itself, so that we raise awareness for it. So that was Claire, which was, oh my goodness, she gave so much information, which was great. So thank you so much to Claire again for coming and taking us through a journey around family planning and pregnancy.